Hi, everybody, and welcome to the Mind on Mental Health podcast. My name is Andy Dean, and I'm a licensed clinical social worker. Today, I'm once again speaking with Dr. Becca Boswell, Director of Princeton Center for Eating Disorders and Administrative Director of Psychiatric Services at Penn Medicine Princeton Medical Center. On this episode, Dr. Boswell and I discuss GI issues that present challenges in eating disorder recovery and how to stay motivated. So I hope you enjoy the podcast and find it helpful. Is there any current research that you find compelling in terms of a specific modality or eating disorder treatment in general that gives you hope for the future? Or is there specific research that you find interesting in terms of you wish more therapists would be trained in this particular approach?
Yeah, that's a good question. I actually have a really disappointing answer, which is that I really don't think the field clinically has evolved that much in the past 20 years. Mm-hmm. We sort of have the bread and butter treatments, so CBT and sort of integrating some of the third wave approaches and sort of building more integrative frameworks for patients, but hasn't really shifted in a dynamic way since. Mm-hmm. And the treatments, we're still getting them disseminated to clinicians, right? There's plenty of non-evidence-based eating disorder therapy that's still out there. Okay. And so I think we're at the how do we get people evidence-based treatment phase, and not what's the new exciting treatment modality. Interesting. Unfortunately. Yeah. Right. I do think that not in the eating disorder field, but in psychiatry more broadly, there's more innovation around interventional psychiatry treatments. Would that be what is it? It can be ECT or ketamine or TMS. Those are newer, more innovative treatments that haven't really been tested in eating disorders. There's sort of case studies and tiny approaches around it, but there's no randomized clinical trials around it. That feels like an opportunity for innovation, but the core psychological modalities haven't really shifted at all in the past 20 years. Is there any research that you find compelling in terms of what is working? I mean, the meta-analyses on CBT are pretty good, but they've been pretty good for 20 years. Right. Yeah, I mean, and can you give me a general ballpark or no? I don't mean to put you on the spot. We can totally just cut this out. No, it's okay. What ballpark do you mean? How effective the treatment is. Yeah, so the treatment could be more effective. Okay. So the meta-analyses around CBT or other evidence-based treatments are that about a third of people see clinical remission after those treatments. Okay. And then there's some relapse right after. Mm-hmm. Right? We know some of the moderators of that effect, right? The people that respond faster earlier do better in the long term. Okay. So we still don't know how to get above that 33%, right? A third of people get better, and then we just keep trying. Okay. I think something that does give me hope, and it was, there was a longitudinal study that looked at folks with anorexia and bulimia over 20 years. And even in the context of multiple treatment episodes and long-standing symptoms, more and more people continue to recover even 10 years after their initial treatment episode. Oh, that's great. So there's always hope, right? That it'll click at some point in life. Mm-hmm. And the longer you give, right, engagement with treatment, the better the outcomes are. Mm-hmm. I could see that being useful clinically or just from a psychoeducational perspective. Yeah, we read that paper with our patients all the time. Okay, because essentially there's, even if you don't feel like it worked last time, there's always hope that it might click this time. Right, you might need multiple doses to be able to find an effect, and that's okay. That's a reasonable treatment trajectory for 66% of people. Yeah, yeah. And even those people continue to have hope the longer they engage in treatment. Okay. And I think that runs counter to a narrative in eating disorder care around long-standing illness or terminal illness, which is very controversial and not a belief that matches what we see in treatment trajectory data. Okay. I would like to ask you more about that. Sure. Yeah. How do you think about that? Because I don't mean to keep putting this through my own lens, but with severe OCD, I always kind of it as something that is looking for a way in. Even if the person is not symptomatic for a while or whatever, we kind of always want to be aware of it as so that we can intervene early so it doesn't sort of take off and take on a life of its own again, right? Is that similar to how you would think about eating disorders, or is it different? Yeah, so I think that eating disorders, right, like and all the medical complications of them and all the ways that people can die from them are treatable with food, right, and with psychiatric treatment and psychological treatment. And so it's different than someone who has cancer, right? Like who might have sort of an estimated timeline for like how long they have left in their life and might be, you know, diagnosed with a terminal illness. I think about if we were to continue that metaphor around cancer, right? Like each episode of eating disorder care is like we're treating the tumor, right? And like the tumor shrinks, right? But you have to be vigilant around like, is it gonna come back?
Okay.
And might need multiple episodes of treatment depending on how strong that tumor is, right? But sort of follow the treatment, treat the symptoms that come up, and hold hope, right, that you could be cancer-free for a period of time.
Right. Okay. Yeah, I like that analogy.
Yeah.
You had brought up, when I was asking about the levels of care, GI issues that can come up.
Yeah.
And I was just curious if you could tell me more about this, because like as I was thinking about this, that seems tricky to me, because if you're physically feeling uncomfortable, that's more of a reinforcer to keep doing whatever the behavior is that's keeping you stuck.
Yeah.
So I'm just curious what some of the challenges are with that. Like what happens in the GI system when you're malnourished or...
Yeah, GI concerns are a universal part of eating disorder treatment at any level of care. At our inpatient level of care, every single patient has GI discomfort and has to work through that discomfort to continue to take their medicine, right? Like the food is the medicine, and it also causes a side effect of a lot of GI discomfort. The reason for the
So if someone has an eating disorder, just even after eating food, they feel discomfort.
They can.
They can, right.
So a healthy GI system sort of like has the right amount of enzymes and digestive hormones that are available in the gut and the stomach to help break down food. And then the intestines are kind of like a tube that's like a muscle tube, so it like squeezes things through. And a really healthy GI system has a strong muscle, can move things through quickly, has the right amount of things to digest all the different food in like an appropriate way. But a malnourished GI system stops having that.
Yeah.
So it produces less of the hormones you need to digest. It delays emptying the stomach, which can cause a lot of nausea and bloating, to like suck out more nutrients, right? And then in the intestines, right, they can become deconditioned. They get less strength, right? Because when they're malnourished, right, like tissue comes from everywhere to like keep your body going.
Oh, okay.
And so people's intestines lose muscle tone, just like other organs, right? People's hearts lose muscle tone, people's brains lose white matter and gray matter, right, when they're malnourished, and so everything shrinks.
So that's an interesting way to think. It's like the muscles have atrophied essentially that help you digest food.
They haven't had enough practice.
Right.
And so in a deconditioned GI system, there's going to be burping and bloating and pain and discomfort. That's part of the reconditioning process. And there's really no other way through it. It's that you've lost the muscle in your GI system to digest food in an easy way and need to rebuild that through time, which takes quite a bit of time. It can take 6 months, it can take a year, it could never get better. And really there's no way through it other than through it. Fortunately, there are some good comfort medications that help. So there's medications that can help with gas or bloating or nausea that we use all the time to help people feel a bit more comfortable. But it is an unfortunate, consequence of the eating disorder.
Yeah, I mean, I would just think that clinically, that's a significant challenge.
It is, and I think, patients don't often get that education around the malnutrition effects on their GI system, or enough education about, right, like the pain signaling in their gut and what it means. So we tend to use a lot of GI adapted interventions, like from CBT or from, relaxation strategies around it to help people consider that as like my body's working really hard to protect me and get stronger, and not there's an alarm and something's wrong in my digestive system.
Got it. Okay, so like I like to use a lot of working out metaphors, which maybe I don't know if that's appropriate in this case or not.
It's okay.
But you kind
working out can be neutral.
Okay, you can kind of think of like the act of lifting weights or pushing yourself physically to build muscle as in the moment it's uncomfortable, but like over the long term, you're getting stronger.
Yeah, the soreness is healing.
Right.
Right? So I think that's a metaphor that we use with our patients often. And, talk about the eating disordered way of things is not actually discipline or exercise anymore. That's like the default option once you're really sick. The real discipline and the real exercise is trying something different.
Good point. Okay. I keep wanting to ask you about motivation.
Sure.
Especially when there are these challenges. Like, there's no magic bullet or magic pill for motivation. Once all this discomfort is present, how do you help someone stay motivated?
Yeah, I think there's a lot of support that's needed, right? A lot of praise and acknowledgement of how hard it is to push through a lot of discomfort. A lot of thinking about the future that you're building and like doing all of these hard things. And spending time really reflecting on your values, right? And like a tough moment right now could build a life full of fewer tough moments in the future. And trying to use that sort of like marshmallow test framework of like it's hard now and it'll be good later.
Good point. Thanks everyone for tuning into the podcast. Join us next time as I talk to Dr. Boswell about GLP-1s and how they impact eating disorder treatment. See you then.